Hello, my name is Christina McGann, and today we're going to talk about Rh factor alloimmunization. The definition is rhesus incompatibility. It's the discordant pairing of maternal and fetal Rh types. When an Rh negative person becomes sensitized to the D antigen present on the erythrocytes of an Rh positive blood type, the person makes anti-D antibodies. The anti-D antibodies will attach to the Rh positive red blood cells and will cause the destruction of these blood cells when exposed. Other versions include anti-C, anti-K, anti-E, and but anti-D is the most common. Here's a picture for you of hemolytic disease of the newborn, and you can see how they talk about here where the cells from the newborn, fetus, go into the maternal bloodstream, and you can see these little green guys here are where the maternal body makes antibodies against the baby's blood because of the positive antigen, and then the antibodies go back in through the placental circulation and attach themselves to the fetal red blood cells. Risk factors for mother include a history of blood transfusions, a history of a bone marrow transplant, or needle stick injuries, exposure to fetal Rh positive blood during pregnancy and/or delivery in the past, bleeding during pregnancy, miscarriage, trauma during pregnancy, ectopic or molar pregnancies, and external cephalic version, as well as any other invasive procedures during pregnancy. Pregnancy-related alloantibodies remain in the body longer than those obtained from blood transfusions or bone marrow transplants. Anti-D antibody production is a maternal consequence, and there's no clinical signs or symptoms in the mother. Fetal neonatal consequences include the maternal RBC alloimmunization is the #1 cause of fetal anemia. This situation will cause increased cardiac output and decreased blood viscosity in the fetus. Hemolytic disease of the fetus and the newborn, also called HDFN. And another fetal consequence is increased mortality and morbidity to both the fetus and the neonate. Hydrops fatalis is a life-threatening anemia with 2 or more of the following: ascites, edema, pericardial or pleural effusion. And another consequence to fetal and neonatal is hyperbilirubinemia and kernicterus. Subjective data, the patient may report vaginal bleeding and/or trauma during the pregnancy. They may give a detailed history, including past transfusions, bone marrow transplants, or accidental needle sticks they've experienced. They may be able to report that they received a shot at 28 weeks gestation, after birth, or after having a bleed during past pregnancies. And newborns can't report any subjective data. Objective data for the mother are results from blood typing and antibody screening, current vaginal bleeding of unknown etiology while pregnant, once the blood type and antibodies are known. Invasive procedures such as chorionic villi sampling, amniocentesis, or external cephalic version. Obstetric hemorrhage from placenta previa, visa previa, placental abruption, or uterine rupture. And then abdominal trauma from either domestic violence, a car accident, or a fall. Differentials for the newborn is breast milk jaundice, sepsis, thalassemia, hypothyroidism. One diagnostic test is serum blood testing for ABO group and Rh typing. Rh typing is used to determine if D antigen is present on the erythrocyte of the patient. Blood tests for ABO will determine the patient's blood type. And an example is that AB positive results mean that the blood group is AB and the D antigen is present. Another example is AB negative results, which means that the blood group is AB and there is no D antigen present. Another diagnostic test is a serum antibody screening. This should be done at the initial prenatal visit on all expectant women, and it should be repeated at 24 to 28 weeks gestation on all Rh negative mothers, unless it's been confirmed that the father of the fetus is also Rh negative. If the test is positive at any time, then the test is to be repeated to identify the antibody that is present. And it can be D, big C, little e, or Kel. A third diagnostic test is middle cerebral artery peak systolic velocity. And this is done via ultrasound and is non-invasive. Elevated peak systolic velocity is present in fetal anemia, and this is due to the thinning of the blood and increased cardiac output, as we discussed previously. This diagnostic test allows for serial monitoring without risks that come with invasive testing. However, it's less specific in later gestational pregnancies. This test is considered the gold standard of testing for fetal anemia. A fourth test that can be done is an MRI. An MRI can be used to measure fetal hematocrit levels. It can be used as a contingent test, meaning that they don't usually use it like as the only test, but with other testing. It's best used after an intrauterine transfusion or in later gestational pregnancies, where, like I already explained on the previous slide, that one is not as specific as the gestation increases. And then a result of less than 7, below the mean based on gestational age would be positive for fetal anemia. Other testing that the mother can get done is if she's a Rh negative mother, is antibody positive, then a serum test should be done, testing the Coombs test to guide the plan of care, the further plan of care for the fetus. If vaginal bleeding or trauma occurs during the pregnancy, another serum test that will be ordered is a Kleinhauer-Betke to distinguish if fetal maternal blood cells were combined. Treatment for the mother. The best treatment is to keep alloimmunization from happening. This is done by testing to determine who is Rh negative and then treating during pregnancy. Rh negative women will be given 300 dose of Rhd immunoglobulin between 24 and 20 weeks gestation. They will also be given that same amount if trauma during the pregnancy occurs and an invasive procedure is done, or if interpartum hemorrhaging occurs. However, it's important to note that it's not a standard of care yet to give the Rhd immunoglobulin with every invasive procedure. It's based on provider choice. If the newborn tests Rh positive, then Rh negative mothers need to be given a full dose of the Rhd immunoglobulin within 72 hours of delivery. A full dose should also be administered in miscarriages 13 weeks or greater, and in any miscarriages less than 13 weeks, you give a half dose of 150. Treatment for the fetus is monitoring by maternal fetal medicine, which will include middle cerebral artery peak systolic velocity testing to evaluate when treatment should occur. And they say that treatment should occur once you reach the 1.5 times the appropriate number for gestational age. So they go based off of gestational age, will give you a number, and then once your number from testing reaches 1.5 times that, then we need to do something to actually treat the condition instead of just monitoring it. Treatment may include early delivery, which may be necessary based on that monitoring of antibody levels. And it also needs to be known that the newborn may not be able to, or the fetus may not be able to go through a full term delivery. So they might choose to take the baby early. Another option is an intrauterine transfusion, IUT. This intrauterine transfusion has a 97% survival rate in fetuses without high drops. Here I found a picture for you from the Michigan University School of Medicine that shows how the intrauterine fetal transfusion is done under ultrasound guidance, similar to that of an amniocentesis, but they go into the fetal vein and do the transfusion that way. Continued treatment for the newborn. Excuse me, treatment for the newborn now, before it was the fetus, but the treatment for the newborn will include admittance to the neonatal intensive care unit, exchange transfusion, which is where they replace the newborn RBCs with Rh negative red blood cells, intensive phototherapy to treat the hyperbilirubinemia, which occurs from when red blood cells are broken down, a chemical is released called bilirubin. And then they may or may not do IVIG therapy if the bilirubin levels continue to rise despite the intensive phototherapy, because we're trying to stop kernicterus and permanent brain damage from occurring from the hyperbilirubinemia. Education, referrals, and follow-ups. So we already talked about monitoring. The previous thing we talked about fetal monitoring when I talked about the Doppler tests they would be doing. So referral during pregnancy to maternal fetal medicine, who will be monitoring the fetus. We want to educate the patient on the need to receive her RHD immunoglobulin when it's ordered by the provider to prevent alloimmunization from occurring. I know on a personal basis, I've had patients who come in at like 32, 34 weeks, and they're like, oh, I have this order, and I was supposed to have this done a while ago, but I never got around to it. So we would want to make sure that we educate the patient on the need to follow through with the orders that are given to her by her provider. We want to also educate the patient on the need to notify the provider if there was any abdominal trauma or fall or a car accident that occurred, or if vaginal bleeding occurs during the pregnancy. And we would also want to educate them on why alloimmunization is dangerous for any future pregnancies. Another side note, I personally also educate them, even if they don't plan on having a future pregnancy, that it's always important to still receive what we call RhoGAM, where I'm from, but the RHD immunoglobulin. It's important for them to still receive that just in case an unplanned pregnancy occurs. Their body then would not attack that pregnancy and cause potential life-threatening complications to their fetus and or cause their fetus to pass away in utero. And then these next few slides are just the 6 references that I had that I used when I was making my presentation. So I hope